Hello, and welcome back to the Resting Stitch Face podcast. We're excited to bring you part 2 of our conversation with Dr. Brendan Gallagher. If you caught last week's episode, you know we covered a lot of ground, but there was still so much more to discuss. Today, we're picking up right where we left off and continuing that conversation. This episode is especially fun because it was also released on Dr. Gallagher's podcast, the Dose of Dental podcast. If you enjoyed today's discussion, be sure to head over and show him some love by checking out his show, subscribing, and exploring the great content he's putting out for the dental community. Dr. Gallagher brings a unique perspective and plenty of insight, and we're thrilled to continue this conversation with him. So without further ado, let's jump back into part 2 of our discussion with Dr. Brendan Gallagher.
All right, here we go. On the podcast today, Dr. Erin Sheffield and Dr. Sarah Harding of the Resting Stitch Face podcast. Let's go. So can you give like a quick intro into Resting Stitch Face podcast, and then also individually too?
Well, I'm Erin Sheffield. I'm a board certified oral maxillofacial surgeon. I practice out of rural Illinois. You might see me online at Dr. Erin Sheffield. I am now the founder of the Doctors All In Retreat and community, which is helping women who are getting lost in achievement kind of find themselves again after years of training and caregiving.
And I'm Dr. Sarah Harding, also a board certified oral surgeon. I'm in San Diego, and I spend most of my time raising little boys, picking avocados and coffee, and trying to figure out a good way to sell those. So, hey.
And together we are the Resting Stitch Face podcast.
Yep.
Who came up with that name, by the way?
Erin did.
He's so clever.
All credit goes to Erin. My sister said it was a stupid name because it wouldn't, people that weren't surgeons wouldn't like it. And so I was like, I don't know.
People would think we were like knitting people or embroiderers.
I do like doing that stuff.
And I was like, but I really like it. And then later I was like, can't we just do it? That's my favorite fun.
Yep.
I think it's hilarious. It's great. It's so good. It's on point, you know?
I know, right?
Yeah,
I mean,
we had a whole
I feel
list.
like it's
maxillarious.
maxillarious. Yeah, we had so many. We had like 200 ideas. So if anyone needs a podcast about oral surgery, fighting back with Sarah and Erin, I mean, we had so many ideas, but
that was was that 1 or 2 years ago when you guys got it going? When you finally got it going? Because you were talking about that. I know, Dr. Erin, we were talking about it for a while at
You're right.
3 years ago?
Yeah. We have been recording together for about a year, but we've published for probably a year in July, maybe is when we went live. So we're getting there to our anniversary.
Yeah, we release episode 46 tomorrow, and it's weekly, so pretty good.
46 episodes? I didn't know that there was that many. Yeah. Oh my goodness. Yeah. And also, we were talking about it on our other podcast just moments ago, but I really think it's, well, one, again, thank you guys for coming on today, right?
Thank you for having us.
Nice. But number two, I think it's excellent because what we were talking about is like with mentorship, you really kind of need to see yourself in, kind of see what the mentor's doing to kind of envision yourself, like your career, how you want to work, where you want to work, what you're going to be doing day to day. Are you going to go all in and really get like, you're going to work 7 days a week? Or are you considering other things outside of work that's a part of your life that are important to you? And so I'm so glad that you guys are, you formed a podcast. You're doing everything as far as mentorship, the conferences, which I would like you to give a shout out to quickly in a second. But I was talking with another oral surgery resident, young woman, and that was a big thing for her. It was like in her dental school to kind of see the oral surgery residents, to envision them. And I think we were just talking about this too, from your perspective. So a lot of people have the same issue, the same thing where they need to see a mentor doing it because it's similar to them. That looks like them, that has similar interests as them. And so I think it's so important. And I love that you guys are doing it. Plus, you guys are so much fun to talk to.
Thanks. Yeah. And I agree. It's like you can't start from ground that you can all start from ground zero, right? But why not have somebody there that has done it before you that you can look at and say, okay, I can build from there, right? Because it makes the transition from dental school to residency to private practice or wherever you're going like so much easier, to have somebody that's done it before that you can ask questions of. So I think it's awesome.
And I think sometimes we get hung up on thinking you have to find someone that like looks like me. And I think that's helpful. Like, I think that's one reason I'm a big advocate for like DEI programs because patients, they need to see themselves in you. Like, I think there's a lot of trust that's built with that, and having a good spectrum of the community and the world that you're working in to be able to see themselves. I think that's really important. But sometimes it's less about how you look and more about seeing yourself in the values that they're promoting, the lifestyle that they are living, things like that. So it might be hard when you're a woman oral surgeon to find a female mentor. And again, that's part of why we're doing the Doctors All In retreat and the communities, because we're trying to build that access for women like us. But I think the more important thing is finding someone who's in alignment with your values.
Can you give
Yeah.
a quick information for all listeners, viewers, when the next conference is, where it is, timing, right?
Yeah, it's going to be happening in Austin, Texas, February 26th through 28th, 2027 at the Miraval Resort, which is a fabulous all-inclusive luxury wellness location. It's definitely a different vibe than Amos or the typical stuffy conferences you are going to. You know, you can go and
We
get a
promise we will not
massage.
compare credentials.
Right. We're doing like ropes courses, like climbing and flying above the air. If that's your thing, we're talking more about things like burnout and personal wellness, health, building your practice, things like that. So hopefully it's something that's really going to fill your cup and help you be rested and rejuvenated and excited to go back home to your life and your practice.
I think it's so important. We're talking about burnout on the other thing, but did you guys ever experience burnout? Like any day to day in the beginning, right now, in this moment, maybe today?
Yeah. When I was in the Navy, so I finished residency and I did the HPSP scholarship. So they paid for dental school. And then while I was in dental school, I applied for residency and they said, oh, great, we want you to go out service. And so then I had to apply to civilian programs. So I applied, got into Baylor. And so I was an active duty Navy person while I was in residency. And then after residency, I went straight to a aircraft carrier and deployed, and then came back and then was in clinics on the East Coast and then on the West Coast. And I remember thinking, I don't know if I just don't like oral surgery or if it's just that I'm tired of the Navy, and so like that was my key to I think this is what burnout might feel like. I don't know, because I was just so annoyed with the crap, the day-to-day crap, right? And as it
Yeah.
turns out, it was really probably just a lot of the bureaucracy of the Navy, because I love surgery and I love patients and I love operating on, all of that. And so, yes, I experienced it in that way. How about you, Erin?
Yeah, I think for me, burnout's more of like a moment to moment thing. It can hit me at any time. And I know I'm facing burnout. We said this other day on our podcast. My compassion goes out the window when I'm feeling burnout. That's how I can tell. Because like if I have a unruly sedation, or they're like, oh, I'm like, sit down and shut up. That's what my brain says. I never say that to the patient, where normally it'd be like, it's okay, but I can tell I just don't have that emotional capacity anymore. And usually it's when boundaries have been crossed, when the time, like my schedule has been eked on that I wasn't planning. Something got jumped on me. My nurse has a million questions on top of everything. It's usually, I find it's because I've been asked to do a little too much and not able to like establish those boundaries and control.
That's a great point. That's a great, I definitely know
Mhm.
what you mean, where it's like maybe a certain patient who maybe just isn't understanding, but it's like they have to ask the same question of like seven questions, but after they ask the third time, then they finally move on. And it's like, I guess I said that differently on try number three than try number one.
Yeah.
But then you go into the next patient room and then they ask the question twice. And
Well, I had an
What
example
is
of this
this?
the other day. I try to limit my OR cases to once a month because it used to just be, oh, I go this Wednesday and I go that
Mhm.
Tuesday. And, next thing you know, it's just like, okay, we need to do it once a month. It just needs to go and do a block and be done with it. My schedule needs to be set. It can't be so crazy. And so we were trying to get something arranged. And then this mom calls and was like, I can't do that day. I can only do Mondays. And I was so annoyed. I have Mondays and Wednesdays off. So that's usually when I go to the OR. So do I really care if I go on a Monday or a Wednesday? Not really. But the fact that I felt like she was demanding that day without like, would a Monday be okay? It made me like, we're going
Mm.
on a Wednesday. And I'm like, that is not the kind of doctor I am. Like, if I can accommodate, of course I want to. But my boundaries have been crossed. So then I'm wanting to act in this passive aggressive manner that I normally wouldn't, where again, my big boundary is not feeling appreciated. I don't like to be put upon. I don't like people demanding things from me. So if you would have just said, hey, Mondays are a lot better. If that could work, that would be great. Then that's a much different than like, I only do Mondays, make it happen.
You're like, well, I only operate on Wednesdays. Sorry.
Oh, yeah, exactly. That's how I wanted to respond.
It's not true that patients are getting less polite. Maybe people are just getting less polite in general, but like the rudeness. So I was just talking with a general dentist who's been at it for like 32 years, and he was saying like he doesn't know what it is, but within the last 5 to 10 years ish, he's like, I don't know what it is. Patients are completely different. This is not what the profession was. And
I'll tell you what I think it is. I think that it's because there's competition. And so everybody's offering something, free consultations. Oh, we have late hours on this day. Hey, our office is open on Saturdays. And then so patients are seeing these things and then they're starting to expect it. And so whereas if you go to Mexico, for example, they're like, oh, well, these are our hours. And people are like, oh, I'm so thankful that I was able to get in today. Thank you so much. I feel like the entitlement is exponential now simply because we've been giving little breadcrumbs throughout the profession. And so patients are like, well, he gives that. So why don't you? I want to come to this office and I like you better. And so they compliment you. But I need you to accommodate me in my schedule and all of my things because you're doing surgery on my child. But I need to tell you when you can do surgery on my child.
Yeah.
You're like, okay, well, that doesn't make sense. So I think it's an entitlement thing.
I think it's entitlement. I don't have any competition really. That's the benefit of being in a rural community. So for me, that's not necessarily it, but I think some of it's financial. Like it's so much harder to make a buck. Your buck doesn't go as far. Inflation, all of those things. And I think that's part of it. There's a lot more suspicion and distrust. And some of that comes down to the money. Like, is my dentist trying to scam me? Is my dentist the equivalent of a used car mechanic where they're just trying to make a buck, And then I'm the first to get on social media and defend dentists. Like, no, we went into this because we want to help you. We're here to help. And if you hear you have 10 cavities and the next guy says you has none, that's just a different treatment philosophy. And then you start hearing about people talking about ozone therapy and cavitations and bone grafting third molar sites every time. And then I'm like, I can't defend you guys anymore because you are maybe a scammer. I hope you don't really think in your heart that that's what you're doing and you believe what you're doing, but still that distrust makes it hard to come. And then you're already kind of fired up, and trauma-informed care is one of my big topics that I like to talk about, that understanding people have trauma and this underlying basis that they're meeting you on, and that affects your whole interaction, and that changes it. So they're coming in already kind of hyped up, already full of anxiety. They're not really trusting you. And so then you're kind of digging yourself out of a really deep hole just to like get back to baseline. I think like my husband's a physician and he's ENT. And I think it's so interesting because the way he talks about his experiences, like someone's like, you make kids cry. And then I'm like, he's a pediatric ENT and he probably makes way more kids cry than I do. But like looking in their ears, the parents just like hold him still and look in his ears. It's fine. He's going to cry. But I feel like when we do, it's like, you evil dentist.
Yeah. 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 And probably because they already have their own trauma around dentistry. Maybe they were put in a pedo burrito or whatever it was, right?
For sure. There's a lot to unpack there, but that's kind of
what was that old pediatric philosophy that they used to teach? It was the hand over
mouth.
Is that what it's called?
Yeah. Did you learn that still, Brendan?
I did not learn hand over mouth. I learned voice control.
Sit down and shut up. See, I learned it somewhere.
Yes. Yelling at
I learned it.
Yelling?
Mm-hmm.
The papoose, that was another one. And then tell, show, do. That's a good, that one works.
Is that what the pita burrito? That's what the papoose is the same thing. Yeah.
The pita burrito. Oh, yeah.
She lives in San Diego where that Mexican, influence is strong.
Habla español?
No, we were just in Mexico City and we were both very sad that our Espanol.
So bad. Yes. I got a lot of it. I did my anesthesia at Parkland. And so we had a big Hispanic population there. And so I have some decent anesthesia Spanish, and that's it. Yeah.
It's something. That's something.
Yeah.
I mean, I don't know.
Nice dolor. Is that right? Are you having pain or something? That's
Tiene dolor.
right.
¿Dónde? Abre su boca. Abre su boca. Grande, grande. Yeah.
But I guess not too much anesthesia Spanish in Mexico City. Or maybe there was. I don't know.
It was at an oral surgery conference, so we got a little bit. It was pretty good.
Oh, a little bit. Okay.
Yeah.
Okay.
Yeah.
That sounds fun. Did either of you guys get sick from the water or?
No, and I even brushed my teeth with it. Erin was like, "Are we supposed to brush our teeth with it?" And I was like, "Well, I have been. I seem to be doing okay." Yeah.
Did great. It was great. It was fun. I was speaking at the Mexican Oral Surgery Association meeting. So I brought Sarah as my companion, content creator, emotional support, pal.
Yeah. Eater of tacos extraordinaire.
How were the tacos down there? Better than
Oh my
San
gosh.
Diego?
Oh my gosh. You have not tasted a taco before. You think you have, but I cannot believe. I was like, why do we not have these back home?
And we have good tacos in San Diego,
Mexican people making the tacos. Why are they not making these tacos? That was every meal we were like asking that. Different.
Like at a fancy restaurant and at a not fancy restaurant, at some
Michelin
little
star
corner place
tacos.
on the street.
They were
all the
just
same.
as, like the street tacos were just as good or better than the Michelin star. They were all just like mind-blowingly fabulous. And at one point I was asking our host, like, what is this one? She's like, beef. And I was like, but what is it? I'm like, how do I order this? You know? She's like, it's a tortilla with cheese and beef. And I was like, no, it's not. What is it?
There's something else in there.
Yeah. Like, what kind of crack are they putting in?
This, you know? How do I say this? Yeah, incredible. Yeah, 100%
Oh,
recommend.
man. Well, I'm gonna have to try that.
Yep.
I'm going to Mexico City sometime. Yeah.
It's fabulous.
And they're so welcome.
It was the best. It was the best trip.
Yeah,
It was amazing.
Incredible hosts. That's amazing. Yeah. And
Like,
they've
I'm
got, I
not
think that they've
surprised.
got their next Congress meeting. I think that one of my friends that I made said that their next Congress is in Oaxaca in November.
They
I
move
think.
around.
I guess
We should
so.
go.
Yeah, I think that was the first time in a long time. It's usually by the beach, they said. Yeah, but I think they said that their next one is in November. And interestingly, they said that it's like a requirement for them to go to these meetings. So
Right.
that would be like them requiring everybody to go to Amos
Yeah.
as part of their.
What are your thoughts on that?
Well, and the way that they do it, I think it's awesome because theirs is really fun and it's really collegial and welcoming. And
They
there
had
were
a boxing
assistants.
match
Yes, it was the best.
right there in the hotel.
Yeah, in
They
the
kept
hotel, yeah.
having like behind me as I'm speaking, they kept like showing the ads, you know, for like what's happening for the meeting, and it was like Churritos, world champ boxer, and they're like, "Are you coming to see Churritos?" And I thought 100% it was gonna be like pay-per-view, and then we walk in and there's this giant boxing ring with people boxing in person, like sandwiches and beer.
Yeah, they're handing out beers and sandwiches.
And we're all like,
Yeah.
what? And they're like, you thought it was going to be on TV, you silly Willy. And we're just like,
Yeah. So if Amos was more like that and less like, hi, what are you doing these days? And how many staff do you have? And what's your practice model? And you know, like that,
How many
then
offices
I'd
do
be
you
all
own?
in.
and
Yeah.
they're like, ballet. And next thing you know, you're dancing. You're like, I
That's
don't even know
awesome.
the cumbia, but I'm doing it. Yeah, it was great. And I think it's a small enough community. It'd probably be fun to come and see like the people every time. And I don't know,
Yeah.
I enjoyed it. I listened to many a lecture in Spanish, and I don't even really speak much Spanish. And I thought it was very interesting. Despite being in Spanish, I learned a lot. So we should go next
Yeah,
year.
and they and Britton, they are so
This tacos place.
collaborative. Like they have their own practice, and then they have a couple of other practices a couple other doctors that they work with, and they will go and do bigger cases with them. So they'll just like pop over to so and so's office and do cases with them, or if they are going to the OR, they'll pop over with them. But they're totally different practices. It's not like a group practice. And so it was so cool and so collaborative to see how different they practice. You know, and the guy that I was talking about earlier, he's like, "Oh, I didn't get home until about 8:00 tonight. I was doing a big implant case with my friend at his office." And I'm like, "That's so cool. Like we don't have that." They're
That's
like,
one of
oh,
the
well, now I
things.
have to get a group practice because that's the only way that I can get somebody to come and do things with me. And then you're in your group practice, and then everybody's busy doing their own thing. And so it's hard to coordinate people to do things together. But there, it's just, I think because it's
Regulated.
financial and less regulated and less financial incentive, I think that they are so collaborative. It's so cool.
The malpractice insurance too is a big problem for like us to work in other offices. So it's like there's
Yeah.
so many, like you said, regulations, the rules and regulations and laws really prevent us from kind of collaborating in
Stupid.
that aspect. And
Yeah.
I
And you can't
also
talk about your
one of
fees and you can't talk about anything else. And
what the heck, you know? And one of my one of my assistants is from Mexico. She's actually a trained dentist in
Mhm.
Mexico.
Oh, wow.
Her sister's an orthodontist, and her sister's husband, so her brother-in-law, is an oral surgeon of Mexico.
Oh,
So she was saying like, because we were, through the day, I worked basically the last year with her, and she was saying like it would be much easier, it would be much better, much more financial incentive wise in Mexico. I told her some of the fees that we were getting from the insurance company, and she's like, Doc, you make a lot more money in Mexico. And it's,
no.
if you get more freedom to do that, if there's less you
Mhm.
need regulations to keep things from getting like out of hand or like
Right.
complications from happening,
Yeah.
Yep.
which is also weird because we have a lot of like we general dentists allowing basically kind of like do whatever they want except for
Yes.
orthodontic surgery, which is another topic for another day, I guess. But
Yeah.
Mm.
And they
yeah,
can
we
even
have
label
rules.
themselves as an oral surgeon on their Facebook business page, which I just found the other day. So there you go.
Yeah, that too. That too.
Yeah.
So I don't know. It's so confusing.
Yeah. Well, and I found that they are doing more full scope stuff too. They're still maintaining that like full scope practice outside of residency, even if they're not based in a hospital, because they can. It's not so regulated. And because here it seems like, oh, those are the people that go to the OR. Those are the people that do the orthodontics in town. Those are the
Mm,
people that do this. But they all are still maintaining it. I just think it's great.
it is great. I'd be curious to see an orthodontic surgery case in Mexico, just broad scope. Like, is it reimbursed by insurance? Does the patient have to pay out of pocket? If it is reimbursed by insurance, how much is it? Because like I
Mhm.
know one of the attendings told me last year they're getting like $600 a jaw from some insurances here in New York in the hospital, and it's like you just can't. I can't take a day off from work.
That's like
You guys get
one
it.
third molar with like less than one third molar with sedation. Like it's crazy.
Like what are we doing here? What do we do? Like, do we want people to get care? Then
But
what is
Right.
that even an insurance
I'm spending
anymore? It's like
hours
what is that?
cutting your face off and putting it back together and caring for you for weeks
And
leading up
all the
and
pre-op, all the
after for
post.
$600 and the liability. It's crazy.
Months
Yeah.
to plan, months to follow up. Yeah, like what?
It's crazy.
How? Anyway. So
Yeah.
we really jumped into a lot of things right off the get go. Can we just? We got to get to that post, by the way, about the comment that I got literally this morning. But first, can we? No, Dr. Sheffield, we kind of went into this a little bit on our last podcast, part one. This was like a year ago or so, maybe a little longer. But can you guys just give a little, like, I want to, like, just for listeners, viewers, refresh them, and also Dr. Harding, who don't know, like, obviously San Diego, right? But like where you're practicing right now, you said urban versus rural or subs, and then how many days a week you're working, what your office looks like, how many days you're going to the OR. Dr. Harden, you were talking about how building in the pediatric office. I want to know all about this, and I know the viewers want to know too. They want to, we're talking about the mentorship. Let them really embrace kind of your situation right now, like what you're doing, what the vision is, what the goal is, what you're doing day to day, if you can, and how you're managing that on top of being, you know, they have a family. You guys have a family,
Right.
and I want to make sure we show that aspect too.
Sure.
Yeah. Well, I'll
Gracias.
start because mine is pretty easy. I am not really working right now. So I finished the Navy in 2023 and I went out into private practice and I was doing 1 to 2 days a week, sometimes more, but around that area. And then that practice was about an hour and 15 minutes each way. And I was not interested in the commute after a while. And so then I left that practice. I've been covering at a practice a little bit closer to me since I was still in the Navy and then continued, but it's not busy enough to keep me busy. And so lately I've just been working with the podcast and then I'm building this little mini practice inside of a pediatric practice. My goal is to not work full time. My goal is to work a couple of days a week, if that, because I really enjoy spending time with my kids. I really enjoy farming and taking care of chickens, doing sourdough, all of the things that you'd expect a 41-year-old woman to be doing. So that's what I'm trying to do. Yeah.
And wait, when did you have your kids? Did you have it while you were in residency or dental
Oh,
school
thank
or
you.
Navy?
Yeah. So I No, I for sure did not have kids in dental school or residency and was told that that could not happen and that wasn't allowed to happen. And then I went to the Navy and then I was deployed. And then after I got back from deployment, then I, met my husband. We got married and then we had a kid. So I was out of residency 4 years, I guess, before I had my first kid. And then I had my second one 3 years later. So I was 34 and 37 when I had my kids. So now they're 7 and 4, two boys.
And that's excellent. And I'm so glad that you said that because that shows the timeline of that you can do it. You can do it. I love that. Thank you.
You can, but it makes it really hard, right? Because those are not your fertile times, right? And so, but I think it's just, I think more and more these days, women are able to have children earlier, which as we're seeing with a lot of times, if you're not, then you're having to go into fertility treatments and things like that. And so thankfully I didn't have to do that. But yeah, I think I was frustrated because it was not on my own timeline. It was basically, so I was told when I could or could not have children. So.
And that's a great point. On that topic, if you could it, like they told you no, could you have? Do you think you could have squeezed that in somewhere, like during residency or dental school? Would you have had it maybe before, had kids maybe before dental school? Like, I want to get the inside of like your mindset and like, if you were to go in hindsight, yes, no, when, how, you know what I mean?
Yeah, I think that if you can do it and you have family support close by, it's just so difficult to afford childcare, right? When you're on a super limited salary. If you have family support close by, then it's possible. There's literally no way that I could have done it in my residency. I would have been fired. And I know that you're not allowed to do that, but they would have made it happen because I wasn't the first female resident that they told something like that. There was one, she finished probably 20 years before me, but they told she like had a pregnancy scare and the chairman called her in. This is a different chairman, but he was one of my attendings. But he called her into the office and the whole building could hear him screaming at her.
Well, tell him what they said to you.
So when I just posted about this because we talked about this in our last episode, but my 3rd year of residency, I was off service. I think I was on oculoplastics. And one of my attendings called me and said, "Hey, I need you to come over to the dental school because I need you to have a meeting or whatever." And I'm like, "Oh dear." And so I went to the dental school and the oculoplastic practice was up at a different town. But he called me in from off service and I came and I sat down and it was like this airing of grievances. And there was a bunch of things, I've heard that you said that you were just a dentist and he got all upset about that because it was part of that movie. I don't remember, what is it called? Hangover. And then he said, "And I've heard that you want to be a wife and a mother. And if that's the case, you should cut your losses and cut the Navy's losses and leave now."
Wait, Dr. Arden, it's coming in and out
now
again.
Now it says trying to reconnect. Hold on, let me switch my Wi-Fi over real quick. So
Hi.
I'm back.
Wait,
So
what's going on with your Wi-Fi?
I live in the sticks. So I just switched over to
I feel like I should do the dramatic retelling. Because
Is she really out there in the sticks? I guess so.
yeah, she lives on an avocado farm. Oh, I hear her
I'm back.
laughing now like the Cheshire cat before I could see you.
All right, I'm back.
There she
All
is.
right.
Oh, all right.
That
So,
pause is for
you said
dramatic.
Yes.
this
Yeah.
grievances and you came in the meeting.
Yeah. So then he says, and it's him and then a couple of other attendings. And so you think somebody here's got my back, right? No. So it was, and I also heard that you want to be a wife and a mother. And if that's the case, then you should cut your losses and cut the Navy's losses and leave now. Yep. As a 3rd year of 4th. And of course, what do? I cry, right? Because that's just how I react. So
Of
that was great.
course.
Yeah. And so I didn't even have a boyfriend at the time, as it turns out. So
What? You didn't have a boyfriend at the time and they're talking to you as if you're married with a kid on the
yeah.
Which is so crazy because everyone knows if you're a resident and you go a man down, like that is killer for everyone in the program. So why don't you want to like eke out as far as you could go,
Yeah.
Like it's just ridiculous.
He was just mad at me, I mean, whatever. So, but yeah, that was it's kind of the defining thing with my residency was a lot of that. I had a great experience. Like my residency training was incredible, but there was lots of that thread sewn throughout my residency. And I even filed a complaint after I finished residency with the big school and I had to do like a deposition and all kinds of stuff. And then, yeah, they came back and said, "Oh, we didn't find anything." And then, but one of the guys got fired and the other guy died. So.
Oh, I didn't know that.
Oh, man.
Karma comes back around. Oh.
So.
Oh, my goodness.
That got deep. Sorry.
Oh, I
And it's
mean,
been over
about
10 years
you?
now, like my statute of limitations or whatever you want to call it is expired. So,
God, God, I'm sorry to go through that. That's just insane. And it doesn't make
yeah,
the dots don't connect as far as
Man.
yeah,
everything you told.
yeah. So there you go. Now
On
you know.
that note,
Yeah,
Erin, how about
I can dump my trauma next, or we can talk about something more friendly.
let's get into the trauma. Wait, let's go.
Okay.
Let's keep it going. Let's keep the stories going. I want to hear this. I wanna
Okay.
learn it.
I was a new resident out of residency in my first job. It was hard to find a job because I was in Iowa City, which is oversaturated with people because of the university. And so I finally found a job like May as I'm graduating, end of April. And I was going to travel 75 miles commute each way to reopen a practice that had been closed because the doctor was out after hurting their back. So I took this on, and it was going great, but I was also going through IVF treatment trying to get pregnant. And I finally, after many, many, many rounds of treatment, got pregnant. I even changed the timing to if I did get pregnant, then hopefully that'd be better timing for the practice, and that was hard, like waiting when you're just like going through this. Like, I'm already getting pregnant much later if I get pregnant at all than I'd anticipated. And so I finally got pregnant, finds out I'm pregnant with triplets. I didn't put 3 embryos in, by the way. I did 2 and 1 split, so I had triplets. Ended up losing one of the babies very early on, and so continued with my twin pregnancy, went into preterm labor at like 32 weeks, was able to carry the twins till 36 weeks. I worked up until the day before I had the babies. I even had to go in, my ACLS was up to be renewed. And at that one, all I had to do was do some online training and then do CPR on the dummy with it connected to the computer to find out if you're doing it good enough. And I went,
Oh.
I was huge. I was like a whale. I was so big. And I go down to the hospital education center and I'm doing CPR, 36 weeks pregnant, going to deliver twins the next day. And I failed the second round. And they were like, "Oh, it's okay. I can tell you know what you're doing. You're just getting tired." And I was like, "Yep." And all these people kept like ducking out around the doors just because, they're going, "You gotta see this lady who's doing CPR. It's crazy." So anyway, that's like the context. So I like worked up until basically the day I delivered. I delivered like the next day. I had preeclampsia or not. They had to deliver me early. And so when I was going to come back, or they were going to get a locums person, they couldn't. And so they were mad at me for taking maternity leave. And so when I came back, it was a very hostile environment and they were trying to bully me to come back early, even though like I had preemie twins that were having some health issues and I was still recovering from this traumatic delivery where like I almost died too. And so they were really mad at me. And so when I came back, it was pretty unpleasant environment being there. And I ended up recruiting a graduating resident to come join our practice, thinking that, okay, I could go part-time so I can be home with these babies instead of commuting 75 miles each way every single day. And so they signed him on. It's supposed to be like a 2.5-man practice. And as soon as he signed on, they let me know that they're letting me go. And they told me like, now that you're a parent, we know what we would want to do and we'd want to be home with our kids type of thing. So here I was without a job. I'm without a job. Again, it's an oversaturated market. My husband's MD, PhD, ENT, going into fellowship. So we're like stuck in Iowa City for a million years. So I filed for unemployment. And you never think after doing like 13 years of training that you're going to be dropping off job applications at Burger King, collecting your $600 unemployment check because you're the breadwinner for your family of 4.
On top of your 2 newborns, yeah.
So it's crazy. It's how things go.
I bet you would have been the best hamburger flipper that ever existed with those skills.
I honestly thought about that. I'm like, I could be so good at that now. I would flip it with so much joy. People just be getting love and light and service from me with every bite.
Passion.
Yeah, exactly. Showing up
every time.
Charbroiled or I don't know, whatever. So yeah. But yeah, that was really hard to go through. Definitely kind of shook up my identity and
It's just
tough. Yeah. And so unfair. So I filed with the EEOC, which if you ever have a discrimination case, I think some key points to know is like there is a timeline. So you have to file in a short period of time. And then the state of Iowa did find, after a very extensive, like 1 year or longer thing, and he also died, by the way. Going back to Sarah in the process. That's what made it kind of tricky to like continue with our filing, but that's sad and that's too bad for him. But they did find probable cause that discrimination had occurred. So a lot of people are like, you're just a terrible employee. Well, the state of Iowa said that's probably not really what happened. So, and it's hard to get those. They hardly ever come down with that. You have to have a lot of evidence. So I had like hundreds and hundreds of pages of things, but yeah, so that's where we're coming back from, discrimination.
Yeah.
So we ended up coming to an agreement through mediation after very long, drawn out legal.
So is that just with his estate, or how did that work? Since he'd already passed away.
Yeah, I mean,
Or the
the wife
office?
was the practice manager and really the one that most of the harassment and the, egregious things came from. So we continued
like the
against
wife?
the estate.
It was the wife? Oh, I thought it was the practice owner the whole time. Oh,
He
my
was sick and
God.
hardly around, like.
It was the wife.
Mm-hmm. That's the same reason why my orthodontic rotation with a really prominent oral surgeon got cut short from 2 months, which is what everybody else got, to 1 month, because the wife office manager felt that it was not a safe environment for a female resident to be alone in the office with her husband.
Which is really just a pretty blonde.
So I didn't get the full experience.
He's
so terrible.
We're getting into the nitty gritty with good stories today.
See that?
What I mean, why are we giving him all our best stuff, Sarah?
I know.
Or maybe just come to the Resting Stitch Face podcast for even nitty gritty details.
That too. Yeah. Man. And also, so now you're practicing in Illinois, and then where also, how many days a week? I know you were talking before, it was Tuesday, Thursday, Friday, and then Monday and Wednesdays off, but just to kind of give the layout, or also the trend, like were you working a certain number of days in the beginning versus now? You also mentioned, did you mention sometimes you work with your husband because he's ENT or no?
Yeah. So my husband and I both took jobs at Quincy Medical Group, which is a big multi-specialty physicians group. So I feel like it's really unusual. It's not a hospital. It used to be a doctor-owned practice. Now we're kind of owned by VC. But so we're both in this big doctor group, over 100 doctors. So I work at a separate facility. My partner, who's an oral surgeon, we have our own on-site clinic, but they have like a bigger campus where my husband works. So I don't see him directly very often, but we definitely will do OR cases together if there's something that, is of interest or would be helpful. So like I was recently placing a recon bar on an osteomyelitis patient. And so it was just like, people don't know how to help me with this. I need an extra set of hands. So it was really nice that like I got done with my cases early. I'll pop over. So that kind of stuff. Or he'll be like, "Ooh, I don't feel super comfortable with this mouth thing. Will you come help me?" So that part's fun. And people act like, ENT, I can't believe you could marry an ENT. What a rivalry. But it's matched up really well for us. So that's been fun.
Yeah.
Yeah. So we both work at this group. It's nice because basically, less so because, venture capital, but corporate medicine, it takes away some of the autonomy that's kind of leaking down over time. But for the most part, it's kind of like having the benefits of being an associate. Like I don't have to do all of the marketing or the hiring or all of those kind of things. I can kind of show up, but I can also have a little bit of a say. So it feels more like being a partner as far as ownership of the decision making, etc. But you have the support. So at least initially, it was kind of the best of both worlds. So again, we're kind of trickling some of that autonomy away.
Yeah, and then, Erin, can you tell them a little bit about the difference, because you don't have an MD, and so because it's a physician multi-specialty group, there is like a nuanced part of that that you're not getting the full benefit of it.
I'm technically not a partner like my husband is because I'm not an MD. So my partner is a dual degree MD, but the state of Illinois says you cannot own a medical group if you're a non-medical doctor. And so they don't allow me to. So most of the time it's fine, but there are little things like profits from our surgery center I don't get to participate in. I only get my share of the profits. Or if we sell to venture capital, again, how it works every 5 years, I don't get part of that sale unless they decide to throw me a bone. Like last time they gave me like a third of the sale price just like to be nice. So I don't get to vote or be on any board or anything like that. So that's a little bit frustrating. So it's not a model necessarily built for dentistry, and for the most part it's fine, but every once in a while there's just little nuances where it's kind of frustrating. But overall we've been very happy, and again, we live in a smaller town than I ever anticipated living in, but it's been really great for our family. You know, our income is high, our expenses are low, there's no traffic, even though people complain in town that there is, you know, things like that. It's really a nice option. I don't really have to do any marketing. Like I get people, I'm sure you do too, every day in my DMs like, "Hey doctor, I love your content. I would love to help you get more patients." And I'm like, I have too many patients. My partner's out on sick leave right now, so I'm booking out till probably October. So I have too many patients, if anything. But
Isn't this funny? It's like in direct contrast to what you and I experience, Brendan, right? Low income, high cost of living, so much traffic,
yeah, and I
begging for
mean,
patients.
that's something I recommend. I mean, you feel like I want to live in New York. I want to be in the big city. I want to live in San Diego. I want to live the sunshiny
Yeah.
life. And that's amazing, but you pay for it in other ways. And me, like, I can take as much vacation as I want. My house costs $340,000.
I can't even get an ADU for that.
Like, I don't have to market for patients, you know, like there's a demand, and there's something really wonderful about like hanging your shingle and having people just so glad you're there, you know? So
Yeah.
paperwork for the 12,000 patients I saw. So, I mean, if people are looking, I think a lot of those opportunities, people snub their nose at them, but there is some really golden opportunities out there to consider. So if anyone has questions, DM me. I'm happy to talk about my experience, but I thought I grew up in a town of like 200,000. I'm from Utah. And if you're from Utah, you know, there's not like huge cities, but it's a big urban, like everyone's just like in a strip of people. And so it feels a lot bigger. There's traffic and all that. But so I thought like, oh, moving to Iowa City seemed like a whoa, that's not very many people. And then moving to Quincy seemed like even more of a downgrade, but we've been really happy. So it definitely works for our family. It's an easy pace of life. There's a lot of benefits to the lifestyle we're living. But yeah, lower stress for sure.
Where's your husband from? Was he also from Utah or
He's
Illinois?
from Iowa City. Yeah, his
That's he's
father's
from.
a physician, scientist at the University of Iowa for the past like 30 years. So that's where he's from mostly. Yeah.
Wow. It's funny you mentioned that. I was like, the whole time I'm thinking about like you in the OR, and all of a sudden, you know, your patient needs a fest or something. You're like, "Hey, coffee, come here, get this fest done for me. Help me out."
Sometimes,
but
maybe. Yeah, if only, huh? I mean, we could definitely arrange that for sure. Yeah, definitely. That part's nice. I work 3 days a week most of the time. It's nice because if I'm going on vacation and I don't want to take the time off, I'll just work a couple extra days before and after or whatever. So that makes it really flexible. And then I spend a lot of my extra time on my side gig, which is the doctor's all in, content creation, and all of that.
my question was going to ask, how big is your office? Because you said you have a partner. Can you both work in the same office? How many chairs do you have?
We have 5 chairs. We have 2 assigned to each other, and then a third one that we kind of share for consults and things like that. I would
Great.
love
Yeah,
to
that's
have
great.
more, but I'm greedy. Now that he's gone, I guess I have more.
That's excellent.
Brendan, do you
Yeah.
find in New York that itinerant surgery or surgeons going because they're in a highly saturated sort of area? Here in California, we have a lot of general offices that are wanting to bring a surgeon in. Is that a big thing there as well?
Yes, it is. I think it has to do with the taxes, the overhead, the real estate, and everything. I'm noticing that was one of the things the bosses at the practice want us to go out and network and gain referrals and stuff. And so I did, right, and I did very hey, come on the podcast, like, hey, can you meet here for dinner? Just bring them donuts. I brought orchids to a couple practices, so I met a lot of people, regardless of how he looked at that. But I met a lot of people, and there's like the older dentists who are in their practices, whether private or DSO. They've all referred to the same oral surgeon for 25 plus years, right? They're not going to refer to me. Get it?
Yeah, you're not
get it.
going to bring.
Yep.
It's the younger-ish dentists that I need to go out and meet, right? So then I go out and meet them, and there's 2 groups. There's some who are doing like everything. They own their own practice or they're working towards it, but they do everything themselves. They're doing third molars. They're doing all the implants. They're doing clear aligners. They're doing molar root canals. And so it's like, unless I'm going to come in and do sedation and bring on for the all-on-4 surgeries for the practice, it's like, they're not going to refer, they don't refer out anything. If they do, I don't know. I don't know where it goes, but that's that. So they're doing most of their stuff in-house. And then there's the younger general dentists who are doing they're not doing all those procedures, but they're at a DSO. So the DSO either has the surgeon or periodontist come in house, or they own the surgeon or periodontist group to send to. So now if you're in a private practice group that's kind of in the middle, it's not a DSO, it is private, but for a younger associate, where do you go? It's really just comes down to who are they sending us, the people, because we take the insurance that these other groups are not taking. Those are literally the only cases that I would get, or super high anxiety needs to be sedated, right? Like, and then that's the cases we get. So yes, to answer your question, absolutely. Some of them were like, why don't you come work in my office on a Saturday, one Saturday a month, and we do an all X or something. And it's like, it would be great, but that was not conducive to what my boss wanted at that group. So it's difficult in these very high competitive, saturated, high tax, high insurance.
It's not at all what we thought it was going to look like.
And I am so lucky because I still get the please TE number 8, like all the time, like I feel like that's your easiest one to take out. And I still get those all the time, which is really nice. My dentists are busy enough. What?
Do you graft it?
I don't know if he wants to open up that bombshell of a topic.
No, we still haven't even gotten to third molars.
We're bringing all the hot tea for you today.
Oh man, let's talk about that, because there was a post that you had just put up a little while ago or so on and so forth. No, this was like a week and a half ago, I believe. And so we were talking about how you put up a post of how here's a reason why we take out third molars, and it was maxillary third molars, and it was basically destroying the distal, the back end of the second molar. So now you're taking out 2 teeth rather than just the wisdom tooth before it causes all these potential problems. And then I had said to you, because we kind of like intro this for listeners, I had said to you literally just this morning, I got a comment on a YouTube post and someone was saying like, why would you take out I was talking about how, we take out third molars to prevent, sometimes not every third molar is meant to be taken out. No, we don't take out everyone, but many of them have the potential to cause problems, destructive problems. And so the comment was like, why would you take that out? That's like taking out the spare tire of your car. And I'm like, what, like, and I know a lot of other countries, they just wait until third molars become problems to take them out. That is one way of doing things. But now it's like, you could have fixed a problem for like, that was nothing. You heal better, you recover better, less swelling, less potential for long-term complications, less potential of that leading into another tooth that needs to be removed now. So why not? And this isn't for every patient, right? But it's like a good more than 50%. Let's do this let's make this a light topic. I know but what are your thoughts on that? What sparked your thoughts to make that post, Dr. Sheffield?
Well, it's just disappointing when you have someone come in and they're thinking they're getting their wisdom teeth out, and then you have to tell them you have to have your second molars out also. And it happened to me. I just took one out again on Friday on a friend's child. Like, sorry, number 15 is being resorbed, so we got to take it out. And yes, this time we left the spare tire, number 16, but like, I don't know. I'm not an orthodontist. I'm not seeing these cases long term. I don't usually see these teeth magically appearing in the right position, especially when you're like 20 years old, it's not usually going to happen. It's usually going to come in sideways in a funny spot, or
you get perio issues on the mesial.
Yeah, or I had maybe a different thing, but similar vibe. This patient came in and they're like, I think he needs a biopsy. He's got this really thickened leukoplakia. And you're like, oh, the adjacent tooth is super erupted and pounding on that tissue. So let's take it out and see if that resolves the trauma to the tissue, So there's so many reasons that we remove them preventively. And people like to argue, but I was lecturing on third molars in Mexico City, and one of the points I was making was they've done studies that actually have shown it might actually be more expensive to maintain the wisdom teeth, or to maintain and then have to remove them later with all of the problems. So it's actually cheaper to like bite the bullet, get out when you're a young teenager before you even have the complications, instead of like limping along. So I think all oral surgeons
Mhm.
would love to have like a consult with that 14, 15, 16-year-old before we're having to have those awkward conversations of like, the nerve and what do we do?
If you're
Yeah.
wondering
And
why I'm going into pediatric practice, there you go.
there you
Yeah.
go.
See?
Yeah. And just to harp on that really quickly, like with the third molars, say you take out the second molar and then you think the orthodontist might have a chance. One of my best friends is an orthodontist, and he said most of the time they can't move a third molar that distance. They're like,
Yeah.
it's core to the
Mm.
bone on the bottom or the maxilla, it might be different, but the fact of the matter, it's gonna want to tilt measly
They
every
always
time.
tilt.
It's a very long distance. It's not like moving an incisor or a premolar with one root. This thing's got
Mhm.
two roots on it. On the max, it's got three. Moving at
Or
that
more.
distance, it's
Yeah.
gonna tilt, and it's like most of the time you can't do that unless maybe, and they're like 15 years old. So it's the 90% or more of the time.
Yep.
It's like,
I mean, I guess the
what?
times I wouldn't tell, but like, think of how many x-rays you have where you're going like, did you have a tooth removed when you were a kid? Because I can see it's like in the right spot. It just doesn't look right on the x-ray.
Mhm.
And then how
Yeah.
many thirds do you take out? They're just like weird, man. They're like small or like really long, triangular shaped, or like they're not teeth to keep. They're
Yeah.
not worth
That's
keeping
true. That is true.
often.
Like the spare tire, like the little skinny one, that people will put
That's
on.
a good
Yeah.
analogy. Yeah,
Yeah.
exactly.
Yeah. And you don't want to drive around forever on that thing. That's for sure.
But there is stuff
So,
going
Yeah,
around on
right?
social media, and I know we've had these conversations like on texting before too. Like, who is spreading all this misinformation? Things like it's a scam. The $1 billion wisdom tooth industry is just trying
Oh,
to scam you. And you're talking about like other countries aren't necessarily removing them preventively, but one, they've shown that's a higher cost, but two, it's a higher cost as far as patients go because yes, less people are having third molar complications because less people are having them removed. But when you have them removed, there's already some complication that's making you take them out. And then they're
mhm.
older. And we all know after age 25, pretty much every bad thing that could happen is more likely to happen. So a
Mhm.
lot higher chance of having nerve damage and nerve damage without recovery,
mhm,
having periodontal defect, having damage to the adjacent teeth, having some kind of pathology that's destructive to the anatomy in the area, et cetera. The preventive model, I mean, we get paid to say that, right? Like if we take out thirds, we get paid, but it's so much easier and recovery is so much better.
Yeah. And the other
yeah,
thought that I've had a lot is that the American diet really contributes a lot to the reason why we need to
mm,
be more preventive in our treatment of third molars. Because if you think about the diet in foreign countries, there's a lot less processed food. They're
yep,
actually using they're chewing more. They're just it's just different, right? And so the way that we eat here just isn't conducive to sitting around and waiting for it to blow up. 'Cause that's what's gonna happen.
right, man. Another thing was, yeah, and younger, you more likely to recover if there was that nerve injury, paresthesia. But another thing was that cavitation surgery. Let's hit on that topic real quick. Again, another post. It was a LinkedIn comment. Two comments actually. Most people supported, like, yeah, that's ridiculous. You know what I mean? A couple dentists hopped in and they're like, why are we seeing this? Like, because we talked about the cavitation
Mhm.
surgery, ozone or bone grafting third molar sites. And yes, for listeners, sometimes it is beneficial to bone graft third molar sites if there's significant periodontal bone loss on the distal of the second molar.
Especially if you're over
However,
25, yeah.
yeah, but otherwise, the bone's going to grow back to where it needs to be over a couple months. Give it some time. This cavitation surgery, I just had two comments saying that, "Are you even a doctor? How do you not know this exists?" I'm like, "Whoa, wait a minute." Two, another one said, "Yeah, but this is well documented in the literature that bacteria grow in these cavitations." And I'm like, "Great, post the link here." And they're like, "I don't need to tell you where the link, and you're a doctor. Go find it." I'm like, but it's
Yeah,
in your recent search history, which is what you just said you were looking at it this week. Put the
yeah,
link here. You know what I mean? It's always a deflection.
yeah. Also, tell me what part of the body is sterile and without any bacteria,
Your
right?
urine, but they don't like to hear that either.
Yeah,
Well, and it's
yeah.
Word.
frustrating. Yeah, they come back at us as if we are uneducated or we are somehow part of this cog of this industry machine that has a reason to like teach us wrong. And And we're not the ones making money off of that. That's the thing. Like if I wanted to treat cavitations, I could do it. Every single person, like, okay, year after your third molars, come back and we're doing another surgery. And they never charge like $200. It's like, I'm hearing things like, I had $11,000 worth of ozone cavitation thing with pure oxygen bar, like whatever it is. It feels like a lot of these biologic dentists, and not to say some of their stuff may be valid, but I feel like so much it's like this money-making scheme. They're preying on people's fear. They're charging a fortune for these things. It's frustrating. And I even saw a physicians community group on Facebook talking about it this week, saying, my brother got recommended this, and what do you think? And then you're even getting physicians on there like, yeah, it's a thing. I work with this oral surgeon group where we do fibulas to repair people's cavitations, and Austin Ivy, who, if you don't know, Austin Ivy is like the Facebook oral surgery guru. You're like, Austin Ivy, weigh in. And he like had this amazing discourse on it, as he always does. And then they're like, yeah, but ameloblastomas have to be treated. And we're like, calling an ameloblastoma a cavitation, is that accurate? I guess it is a cavitation, but is that a descriptive term that gives us diagnostic information and criteria? No. Like, that doesn't make any sense. It's just like saying, it's kind of like saying leukoplakia. Like, yeah, we can name it, but that doesn't tell us what it is or what needs to be done. So
it's a description. It's not a diagnosis. Yeah.
It's frustrating. And then people, again, going back to the trust, like, well, you're not a good doctor if you don't know about that. You're not up to date on all this stuff. And it's hard to explain some of this quack science away.
Yeah. How do you explain that? Right. Because now you're being painted as the bad guy. And it's like, wait, I'm literally telling you, you don't have to pay me anything because you don't need this.
Yeah.
There's nothing to gain here. Right? We're not being distorted. We're being honest. I wish people would just take a step back and be like, if I do this cavitation or ozone therapy, does that mean I have to need that I need to pay more or not? Right.
Yeah. Meanwhile, we're like, is it okay if we just, if we, I know that it's going to cost a lot for me to take out this tooth, and I'm really sorry, and I'm sorry that it cost this much. And, it's like, we're having to justify that, but then, they've got plenty of other people that are making $11,000 treatment plans for unnecessary treatment. So,
yeah.
Constantly got to dance around. But hey, just one last thing before you guys head out. A lot of viewers have been asking me, give me some feedback, asking if you guys have the time. I know it's getting later, but if we could go over your third molar sequence, like how you remove third molars, which one you start with, which one, and then also the local sequence. If you guys can do that, like the side you start in, you start at the top, so the bottom, how many carpals you use, what carpals you use. If you guys could go through it each, and then we'll call it a day. I know it's getting later.
Sarah, you want to go first?
You want me to start? So my sequence is I'll do 32, 1, 17, 16. So in taking them out. And so then I anesthetize in that same pattern. And I give a carpial of local. So I start anesthetizing on the right side. Lower right, I'll give a carpial of lidocaine as a block. And then I'll give 2/3 to 3/4 of carpial of marcaine as a block. And then I'll give the last little bit of that as a long buckle. And then I'll move up to number 1. I'll give a carpial of lidocaine at number 1. And then I go and I do the same thing on the other side. And then I'll come back with another carpial of, I like to use septicaine, but if I don't have it, oftentimes I'll take another carpial of marcaine and I'll go 1 and 16. Again, just as like before I start, I'll give a little bit of marcaine at 1 and 16.
I like using septo too for a little local infiltrations too.
I usually go 1/17.
Why do you do upper first? I feel like it gets all the blood into my.
I know people say that. It doesn't really bother me most of the time. I feel like they have more time to get numb. Lower takes longer to numb. So I also think, funny enough, I think patients are a little more bothered by the upper ones because I'm relying on force more to get them out. The lowers I'm cutting up so much. So I like to get that done while they're like early in the anesthesia process. The amnesia portion. Maybe that's part of it. And then I do 4 carpials of lido, 1 in each quadrant. And then I do a carpial of marcaine on each lower. That's usually what I do. If I'm doing a coronectomy, which I do probably every day, I will do 1, 16, 17, and then 32. And that's purposeful because I have had too many times where I sit down in the chair. Is that weird or what? I sit down in the chair and I get going, and next thing you know, I'm like, good thing I realized I'm doing a coronectomy here, or I've maybe even taken out a tooth that I was going to do because like my brain, after 10, 15 years of doing this, we just go. We're on like autopilot. And so to me, that tells me and my team, okay, we are doing something different here. Pay attention and remember, because I've been caught a few times. So that's my strategy there.
How about you? What do you do?
That's what you do 1, 16, 17, 32 for the coronectomies?
Mm-hmm.
Interesting. So you do the 2 tops, get them out of the way, and then you get.
And part of it is like emotional thing, like, okay, we like got the easy ones done. Now we're like gonna focus and do this,
Yeah. I like that too, especially when patients are awake, to get the easy ones done because they're super nervous and like,
Yeah.
that was it. And
It
you're like,
kind of
well,
builds rapport.
Spot one might take a little longer, so don't get your hopes up. But
Right.
yeah,
Yeah, definitely.
you're asking what do I do for the local anesthesia? I do 4 carpules of lidocaine. So I'll give no, actually I do 6 carpules of lidocaine and then 1 of septo. So I'll do 1.5 of a block on 32 first, and then to get the lung buckle, and then I do number 1 outside inside, and then I'll do the other side 17, and I'll give 1.5 carpules for the IN block, half a carpule for the lung buckle, and then I'll do 1 carpule palatal for number 16, and then I'll split the septo. I'll do half a septo, just local infiltrations on the buckle of 32, and then the other half on 17. What's your guy? Do you guys have time? What's your when you do IV sedations? What's your like what medications do you like to use? What's your sequence on that? Do you use fentanyl, like kind of things like that?
So in the Navy, we didn't really use propofol. We had it, but they had this regulation where you had to have 2 general anesthesia enabled docs or whatever, in the room in order to do it. And so we just never did it. And so I got away from using propofol, which now I kind of don't really like it. But I usually will just use what I prefer is Versed, fentanyl, and a little bit of ketamine, and like just 25, and I don't redose it. And then depending on the patient, I'll give auxiliaries, right? So like Versed, Decadron, Thordal, things like that.
That's pretty good. What about you, Dr. Sheffield?
I'm old school, man. I'm like a Versed and fentanyl if I can get away with it only. If I feel like it's getting a little hairy, then I'll try to keep that a little lower dose and add in some ketamine. I use propofol sometimes, but I don't like how fast it comes on and off. And I feel like you get in that weird stage 2 where you're fighting people or they're apneic. I just don't like fighting with that. And most of my patients do great with Versed and fentanyl. So that's what I do most of the time.
How about you?
Like that. Yeah, you guys both use fentanyl. I like 6 months ago or so, I just stopped using fentanyl entirely, and I'll give like 5 of Versed, and then I'll give 15 to 20 of ketamine, and then breeding the patient. You know what I mean? Like some patients, heavy alcohol, heavy other stuff, right? Then maybe I'll give a little more ketamine, maybe a little more Versed, like another 2 of Versed later on. But I usually ride that wave, and I'll give little pushes of Prop. I used to fill the stick with like 10 of Prop. Now I'm just doing 6 cc's of Prop, and they ride that Versed ketamine and just a little push of Prop here and there. And I gotta say, it's not as much of like a rodeo surgery.
Yeah.
I'm still learning as I go. So that's been a profound change. And like, I feel like I'm getting somewhere now with learning the sedations, much less of the apneic. Dr. Sheffield mentioned that. Month and a half, I've had 2 brief laryngospasms. One of them, like the SAT dropped to like the 60s, and everything was fine. Everything's fine. Thankfully, like I didn't.
Scary moments.
But like, and if it's a kid too, oh my God, your heart practically stops, jumps out of your chest. But that's the one thing with the ketamine and the increased secretions, that laryngospasm, you need to be suctioning. So anyway.
Yeah.
I don't do kids. I don't do general in my office anymore with kids under probably 12 usually. I used to, but it just didn't seem. We have our own surgery center now, and so it's so easy to go over there, and they've got a range that's much more affordable. It's not that much different than doing it in the clinic, and I just feel like it's not worth it anymore.
It's not.
You spend an hour wrangling them, getting the IV, and sometimes if you can't, the parents are angry at you. Like I've had an issue where like a mom was so mad she left in a huff, and I'd already numbed the child, and the child was like kicking her legs up under the table. And I was trying so hard to get it done. It was just a front tooth and we were already numb, but she lost it. And I said, like, I'm
Oh,
really disappointed in how this is going. And the mom said, I am too. And I thought she meant like about the kid, because like obviously I was doing everything I possibly could. And
Right.
mom's holding her in the lap, got the nitrous going. And then she goes and calls the dentist and tells her how horrible I was, and somehow got in with another dentist who of course got the tooth out, and it was great because they were already freaking numb. Like I already did the hard part, you
oh
know? So it's like,
gosh.
oh, it's just not worth it to me. And if something happened, it just happens so fast on kids that you just don't have nearly the time. So I really like to utilize that option now. But I used to feel kind of strong armed into doing it because, again, I'm the only person in town doing any of this stuff in like a 100-mile radius or more type of thing. And the hospital, when I try to go over there for tooth extraction, can easily cost at least $30,000 for like one tooth. So you feel kind of like, well, I'm trying to help here. And so then you're doing things that you're not really super comfortable doing.
Yeah.
Not that I haven't done it hundreds of times, but I just don't think it's worth it. I think as a parent, I would want to have like the full team there taking care of my
Wow. Yeah.
Yeah.
stuff.
But I've also had the other flip side of that when you bring in a anesthesiologist into the practice for the kids. Because in California, we have a little bit of different regulations. There's certain things you have to add if you're going to see patients under 13, and then you have to have a whole separate pediatric rider on your license for under 7. And so
Mm.
if you have a kid, like I've had kids before and I bring in the anesthesiologist, and I've had some that will tube them and I've had some that will do MAC. And it's so interesting how like they all do things differently too. You know what I mean?
Yeah,
And
we
so
had
sometimes,
anesthesiologists coming in to help us because our surgery center wasn't open yet, and they'd already hired him. And so we're like, this is perfect. We already have one on staff, have him come over. And I hated it so bad. I was like, oh, this will be so efficient and I'm going to feel so safe. He would snow them so deep.
yes,
And I'm like, we don't have to go this deep. We're going to be done in like 2 minutes. And I would be like all worried. And then it would take him like 45 minutes to wake up. And you're like, this just isn't worth it. Like, I don't
never
feel
mind.
any. I'm
Oh,
feeling, and then he's billing for the anesthesia side, but using all of my instrumentation and drugs and stuff. So I'm like, boy, he's really loving this. Like, this just doesn't seem fair, you know? So you have to have some kind of arrangement to make that side make sense too. But
yeah.
I hated it.
Yeah.
It didn't make my life easier or better. So I'll go on your turn and then you do it there, but I didn't like it.
Yeah. Use their materials, their meds and stuff. That makes more sense. So yeah.
Yeah.
No.
Well, guys, thanks so much. This was
Yeah.
what a day. This is a
Thank
great
you.
day. Thank you guys for coming out and doing this and back to back. Like this was great. Thank you.
Thank you.
Yes, this is awesome. Really appreciate it.
Thank you guys. Well, I hope you have a great rest of the week, and I hope we can have a part 3 in like months or at least
Yeah.
within a year. But
Sure.
it'll be fun. I really had a good time with you guys.
You
Yeah, because I
too.
think we've got a lot of changes upcoming, right?
Yes,
See?
we do.
There we go.
Yes,
We got a lot
we
of
Well, I'll
Ooh.
need the updates for sure. And
Yeah.
maybe we'll
All
be
right.
we'll
Thanks
be
so much.
brave enough to talk about bone grafting.
one day. All right. Well, good luck with your hospital privileges.
Thank you. I
And hopefully
still
you
haven't
passed your
received the
boards.
email. I'm actually getting pissed. So I'll let you guys know.
Yeah,
Thank
man.
you.
All right,
Thank
guys,
you.
good night.
Appreciate it.